Hello, good morning. This is Jennifer Barney. I am a AGA CNP student at UTEP, and I will be doing my second H&P presentation or case presentation. The patient came in with a chief complaint of fall from a wheelchair. Patient is a 77-year-old Hispanic female with a past medical history of hypertension, diabetes, dyslipidemia, and hypothyroidism, who presented to the ER with her sister after falling from a wheelchair to the ground. She did report some pain to her right lower extremity. However, patient did deny hitting her head or any changes in her LOC. She is a poor historian, so much of the history is gathered from her sister, who reports that the patient had actually been refusing to take her medications for her chronic conditions for the last 3 months, and since then she has become very weak. The fall actually occurred while the patient was trying to get out from the chair and transfer into her bed. The sister also reported that the patient has been developing some right lower extremity swelling and edema, and she has a wound. The patient denied any fever, nausea, vomiting, any changes in her LOC. She denied any weakness. She did report some weakness, and she reported pain to the right lower extremity. Past medical history includes, again, the diabetes, type 2 hypertension, dyslipidemia, hypothyroidism, and the left BKA she had in 2007. Patient denied any allergies to drugs. Currently not taking any medications. Social history, she does live with her sister. She has never been married, has no children, currently unemployed. She does deny any alcohol or drug use. Family history includes diabetes, type 2, hypertension, and MI on both parents' sides. She said that the sister said that her mom was on dialysis, and both parents had died from heart attacks. On review of systems, the patient denied any fever, night sweats, weight loss, just reported the fatigue. She denied any vision changes or eye pain, any changes in her weight, no polyuria, polydipsia, or polyphagia. Patient also denied chest pain, palpitations, edema. She denied any shortness of breath, dyspnea on exertion, cough, no nausea or vomiting or diarrhea. She denied any dysuria, frequency, or urgency. She denied any joint swelling. However, she did report the pain to her right lower extremity. Denied any changes in her consciousness, no dizziness, paresthesias, or changes in her speech. She did report weakness to both the lower and upper extremities. Denied any depression, anxiety, or hallucinations. On physical exam, the patient's blood pressure was 218/63. Her heart rate was 60. O2 was 96% on room air, and she was breathing about 16 times a minute. And her weight was 84 kilograms. Overall, the patient was a well-developed, nourished Hispanic female who appeared her stated age and in no acute distress. Her eyes were clear sclera. She did have some mild edema to the eyelids bilaterally. Her nares were patent, no deformity. Throat was non-injected. TMs were non-injected. The neck had no lymphadenopathy or masses, no thyromegaly. She did have good carotid pulses with no bruise. Chest expansion was symmetric and clear to auscultation. Her heart rate was borderline Brady, right at 60. No systolic ejection murmur, no rubs, no gallops. She did not have any abdominal masses. She did have bowel sounds present in all 4 quadrants and tympani. For extremity, she did have the left BKA, however, the skin was well approximated and healed. The temperature was warm bilaterally. She did have a left popliteal and right peripheral pulses equal and bilaterally 2+. The skin, again, was pink and tan. On the left shin, she did have a very red ulceration with surrounding erythema and edema that measured about, the ulcer itself was about 5 centimeters in circumference with additional cellulitis around that. Her gait was not tested as she uses a wheelchair and she was actually sitting in the stretcher, but she did have full range of motion and she was alert and oriented and cooperative. Labs, her sodium level was 142, potassium at 2.8, chloride 108, BUN was 34, creatinine was 2.7, glucose level was 127, calcium 8.3, and troponin 0.23. Her RBCs were 3.07, hemoglobin 10.0, hematocrit 29.0, and the RDW standard 49.2, and ketones were negative. EKG was done, which actually showed a heart rate of 60 with a Mobitz type 1 AV block. We did not do a chest x-ray, but we did order one. So getting into our assessment, the patient is a 77-year-old Hispanic female with a past medical history of diabetes, type 2 hypertension, dyslipidemia, and hypothyroidism, who presented to the ER with her sister after a fall from her wheelchair to the ground. The patient did report some pain to the right lower extremity. However, she denied ever hitting her head or having any changes in consciousness. But important to note, the patient had refused to take any of her chronic medications for the past 3 months. Diagnosis for this patient was hypertensive emergency. There are no differentials for that diagnosis because of her blood pressure readings. She also had hypokalemia. Diagnosis was also made for acute coronary syndrome, likely secondary to ischemia. Now, for this, the differentials might include cardiomyopathy. The arrhythmias may be causing the elevated troponin. Elevated troponin can also be caused by a neurological disease, renal failure, pulmonary hypertension. So although the picture presents that the patient's super high blood pressure uncontrolled is causing some demand ischemia, other things should be ruled out as well. Renal function, the patient was diagnosed with AKI. The differentials could include chronic renal disease or acute on chronic. So we don't know her baseline. We don't know, what recent labs she had done, if any, by her PCP, but we do know that she stopped taking her medications. Also, we cannot rule out any kind of infection, so UA was not done in the ER, so we'd like to get one done. So ruling out any infection or obstruction is also important. Is there a reason why those kidneys, that creatinine number is so elevated? For the anemia, the patient had a normocytic normochromic anemia, possibly secondary to chronic inflammation. But with her age and her debilities, we should be ruling out other losses such as GI loss. So maybe gathering some more history about her bowel function, see if there's any changes there. She is a poor historian, so hopefully her sister can provide information, or you can just do an occult stool test. Also do some iron studies or vitamin studies, depending on what we're thinking that the patient is suffering from. But other causes should be reviewed in a patient at 77 years old, not just, anemia of chronic inflammation. Now, well, it very well could be. Now, for the ulcer with the cellulitis, it could be secondary to venous stasis, it could be secondary to diabetes, ischemia, or even a hypertensive ulcer called a Martorell ulcer, and it can also be osteomyelitis. So additional workup should be done there. The Mobitz type 1 AV block, is it due to the ischemia that the patient has had due to uncontrolled diabetes? Is it is it chronic? Is this new? We don't know. So additional, having both an arrhythmia and elevated troponin should be looked at by a cardiologist. Chronic conditions such as diabetes, hypertension, the dyslipidemia, hypothyroidism, those should all be reviewed and treated accordingly. She did suffer a ground level fall and another diagnosis of acute on chronic debility due to the fact that the patient has become more and more weak over the last 3 months. The plan for this patient is to admit her to the ICU due to the hypertensive emergency. CT brain without contrast should be done in order to rule out any kind of cerebral reason why the patient is not a good historian, is weak, plus she fell, and on top of that, she's got the super high blood pressure, and we'll talk about that in just a second. She should have a stat chest x-ray done. The patient is started on Cardine drip. The goal for her was to keep her pressures between 160 to 180 for roughly 6 to 12 hours to see how she managed, how she dealt with that lower pressure, because her pressures have probably been over 200 for quite some time. And then also to keep her diastolic less than 120. And then after that time period, consider bringing that patient's pressure back down below 160. Now, I looked this up, and this is evidence-based on up-to-date that a slow 10 to 20% decline in the first couple of hours should be done, and not just a rapid decline in blood pressure due to the patient's autoregulation. So we'd be depriving her of her cerebral pressures, her renal pressures, which could cause actually even more damage. So she should also have it fully inserted, monitor the urine output hourly, and obtain a UA with micro, again, to look for any kind of infection as a cause for her renal dysfunction. For the hypokalemia, the patient should be treated with 40 milliequivalents of potassium IV and then recheck her potassium level in 6 hours. Patient was started on normal saline at 100. We wanted an echo first before giving her a little bit more and then seeing how she did with her intake to see if she actually was drinking. Cardiac consult for the elevated troponin and the abnormal EKG, and then go ahead and trend those troponins out. The patient was also given aspirin 325 down in the ER ×1, and she should be considered for possibly full anticoagulation therapy or recommended DVT anticoagulation depending on how those troponins trend out. Patient should also have an echocardiogram, 24-hour urine collection, renal and bladder ultrasound to rule out any kind of obstruction. The anemia workup, again, should include the reticulocyte count, a blood smear, serum ferritin and iron, and a TIBC and an occult stool as well. For the wound, the patient was given ceftriaxone 1 gram IV for the cellulitis and the wound care consult, so that way they can get treatment, and also wound culture was requested. The patient should have an x-ray of the lower extremity. This can help to look for gas bubbles and also any kind of osteomyelitis. The patient is started on insulin, Novolog sliding scale, sub-Q, mild sliding scale because she only had a glucose of 127 on admission, so this is done AC and HS. Oh, and she was also ketones negative, so that's good. AM lab should include CBC, CMP, MAGFOS, anemia workup if not already done. We're looking at the TIBC, lipid panel. The lipid panel really, this is a chronic condition of dyslipidemia, but if her lipids aren't controlled, maybe this is a reason for her peripheral vascular disease. We should be doing an A1C and see just how her diabetes is, a TSH and a free T4 if not already done to evaluate her thyroid function. All these things, although these conditions are chronic conditions, they should be assessed in the emergency room because some of these can actually play into why the patient's so hypertensive. What if her thyroid is completely uncontrolled? Additionally, the patient should have PT and OT evals at some point to see just how she's doing. So let's talk a little bit about the etiology of hypertension. Or I'm sorry, hypertensive emergency. So hypertensive emergency is generally classified as a systolic blood pressure greater than 180 or a diastolic greater than 120. Now, for these patients who present to the ER with elevated blood pressures, they may not have signs of end organ damage and are usually asymptomatic. Maybe they're sent from the dentist's office. Maybe they just came in because they had a headache. In any case, we need to be looking up for signs of end organ damage. So an EKG to check heart function, chest x-ray, CMP, cardiac biomarkers, and then considering a CT of the chest and the head to rule out any cardiovascular issues or cerebral ischemia or hemorrhage. Hypertension itself can be classified as either primary or secondary, and they can be caused by genetic factors, obesity, renal disease, poor diet, ETOH, certain medications, aldosteronism, OSA or obstructive sleep apnea, pheochromocytoma, endocrine disorders, and K-rotation of the aorta. According to the CDC, roughly 1 in 3 adults have hypertension and only half of these are controlled. So let's get back into talking about the differentials for this patient. I know we kind of hit on it a little bit in our plan. But for this patient, it's essential to rule out stroke, both ischemic and hemorrhagic, as well as vascular injuries such as an aneurysm of the aorta. Because her blood pressure is so uncontrolled, we don't know if this is her normal, the way she presented is her normal character. Is she out of character? Hopefully we can get a little bit more information from the sister, but CT scan is really going to help rule in or rule out a stroke. And if she were having any kind of blood pressure differences in the extremities or chest pain, shortness of breath, we would do a CT of the chest to rule out an aneurysm just because of the high blood pressure. The CT of the brain is important not only because of the stroke possibility, but also because she fell from her chair, and we don't know if she did hit her head and she just doesn't remember. So again, the goal for any kind of uncontrolled hypertensive patient is to expose any sign of end organ damage. So for her, as well as considering the possibility of stroke, we also want to look at hypertensive encephalopathy in a patient who presents with any kind of confusion or change in alertness. We don't think that she's changed, and she's reported that she hasn't had any changes, but what if this is a reason why she's not wanting to take her meds, and maybe she's just acting a little different at home, and she's got a little bit of a poor memory. So that's also something to consider. Cardiac-wise, the patient should receive a echo to examine left ventricular function. She was started on Cardene, which is helpful in decreasing the myocardial oxygen consumption and decreasing afterload. Beta blockers are also recommended according to UpToDate. However, because of this patient's bradycardia and Mobitz type 1 AV block, they were contraindicated specifically for her. So the doctor did give, the ER doctor downstairs gave a cardizem bolus to help bring that pressure down, and then started on a Cardene drip. Now, cardiac arrhythmias may be secondary to cardiac ischemia. However, this could also be a chronic issue. This could have been her baseline EKG. We don't know. So further evaluation by a cardiologist recommended, and this could include angiography. Again, from the internal medicine standpoint, hospitalist standpoint, what you're going to do is look at prophylaxis. Are we going to start this patient on a daily aspirin? If the reason for her cardiac arrhythmia is due to uncontrolled hypertension, bringing down that hypertension and increasing oxygen consumption, decreasing oxygen consumption and increasing the availability of oxygen is what she needs. So waiting for that cardiologist to see if we need to do any angiography, but as a side note, we'll also start her on anticoagulation with aspirin, with Lovenox, check the lipid level, think about starting her on statins and putting her back on her home meds and all that stuff. Renal-wise, the renal workup would include a renal ultrasound. We want to look to see what's going on inside the kidneys and why they are not happy. Rule out obstruction, gather urine culture if there's signs of infection on the urinalysis. Doing a 24-hour urine collection can help. It helps in calculating the fractional excretion of sodium. It can also help in trending urine volume, so you're actually seeing just how much urine your patient's making. It's likely that these renal issues are secondary to ischemia and hypoperfusion of those kidneys. However, this could be chronic. This could be her baseline. But a 24-hour urine collection and UA renal ultrasound will kind of help guide therapy, and then see if, depending on these results, maybe a nephrologist needs to be brought in order to keep monitoring that patient if they continue to progress into full-on renal failure. In regards to the anemia, in elderly patients, anemia can be caused by multiple causes, and the patient can also have multiple reasons for the anemia at the same time. So this patient has a normocytic and normochromic anemia that could be due to chronic inflammation from her leg infection. However, it could also be due to acute on chronic renal disease, could be due to GI loss. It is essential to rule out any kind of other reasons why the patient is anemic. Giving her back the ability to heal is essential. So boosting up her labs would be great for her healing in her leg. So in regards to her leg, a little bit more information needs to be gathered. So she's a poor historian, and unfortunately when I talked to the patient, the sister wasn't there. She didn't say she didn't get hurt, she didn't hit herself. She said this ulcer just popped up and it started growing. So we don't know, is it a consequence of peripheral vascular disease? Is it diabetes? Is it hypertension? She had a history of a left BKA, and she said that the doctor just told her to take it off. So we don't know if this is due again to diabetes. Did she have an ulcer at that time as well? This was over, 11 years ago, so she doesn't remember a whole lot of the details. Did she have any cardiovascular workup done, any angiography done to the lower extremities. So the cause of her BKA, it would be helpful, and then trying to figure out if she's had any other previous studies, because she's not going to heal if she's got poor circulation. So additional workup might include arterial and or venous ultrasounds, TCPO2s. We already talked about doing an X-ray. You could do an MRI if there's a hint of osteomyelitis or a thought that the patient might have osteomyelitis. You could do an MRI of the extremity, and that kind of will help guide treatment. One of the last things to talk about is all of her chronic issues. Again, we talked about the diabetes, the dyslipidemia. These are things that need to be addressed even though the patient isn't here for those issues. But hypothyroidism, if it's severely uncontrolled, can cause changes in blood pressure. It can cause symptoms of weakness. It can cause the eyelid edema that was found on physical exam. Having poorly controlled sugars as well. You know, if her A1C comes back and it's elevated, this is one of the reasons why that her cellulitis and her ulcer isn't healing. So although this patient came in with a fall from a wheelchair, I will say that she had multiple issues that required lots of workup. Very surprising to have her come in with a 218 systolic blood pressure. Now, I will say that for this patient, because her labs were very normal, she didn't have an elevated Y count, and she didn't have an elevated lactate level. We didn't do any kind of sepsis workup because of the wound. There was no suspicion for sepsis, just infection. So, but that could also be, you know, a presentation. The patient came in with a huge ulcer on their leg, and maybe they fell or they're not feeling good. So, but this patient did not. So she was very interesting. She had a lot of things going on. She will require a lengthy stay, and I'm sure she's not happy about staying and being put back on her medications. But she was an interesting patient. I do want to say that my references for this were extensive. I used pretty much all of UpToDate. Harrison's Principles of Internal Medicine, Critical Care Medicine, Principles and Diagnosis by Perillo, Tintinelli's Emergency Medicine 8th edition, and like I said, pretty much the entire UpToDate series on hypertensive emergency and treatment, as well as elevated troponins and AKI. So that's it. That's my presentation on my hypertensive emergency. I hope you enjoyed and have a good day. Thanks.